Hello, I'm Dr. Omar Bey, and welcome to OBHealthy, our Physicians Health Network. We're here and we're a group of physicians, and we have two primary, well, I should say primary focuses that we really are passionate about. Number one is to improve the health and the health care of people of African. And number two is to encourage young Black males to go into medicine. All right, so today, and this is our December show. And it's a wonderful time in December because this show is a special show for us because we're highlighting the Guyana Medical Mission. And many of the physicians here went on this mission, and it was a wonderful experience. And we're going to highlight that today. All right. Understand the webinar is every second Saturday of each month at 1 o'clock. And please tell friends and family so that we all can enjoy and improve our health. To see our past webinars, you can go to the website, OBHealthy. Just hit the YouTube button, and it will reveal all of our past webinars, and you can look at them there. All right. Please, when you go to YouTube, subscribe so that we can continue to bring this medium to you. All right. I just want to make sure that I catch everything here before we get started. The most important thing that I can say during all of the webinar, and the entire time of the webinar, is please do not change any aspect of your medical care until you consult your physician. Only your private doctor can truly take care of you appropriately medically. All right. What I'd like to do, I'd like for each physician introduce themselves. All right, so we're going to get started here. And as we go, more physicians will join. So understand that we have an exciting webinar for you today. And please let everyone know out there that we started and that, hey, join and then type their questions in. We're eager to answer your questions. Dr. Court, can you start us off, please?
Well, good afternoon, all. My name is Dr. James Court. My practice is located in East Orange, New Jersey. My specialty is internal medicine.
All right, thank you. Dr. Lennox Alves, please.
Good afternoon, everyone. My name is Dr. Lennox Alves. I am a board-certified general surgeon affiliated with East Orange General in Newark, Beth Israel, and my office is located in West Orange. I've been doing this for about 30 years, quite a long time.
Excellent, excellent. Dr. Kevin Clark.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel with most of these gentlemen here. Glad to be here.
All righty. Dr. Kendall Sprott.
Yeah, I'm Kendall Sprott, board-certified pediatrician. I specialized in general pediatrics and pediatric critical care, and I'm now retired.
All right, thank you. Dr. Mazer Ali. Dr.
Hi. So I'm actually coming from the West Coast, so good morning. And my name is Dr. Mazer Ali. I'm a board-certified gastroenterologist. I work at Scripps Clinic in San Diego in Southern California.
Oh, thank you. And Dr. Kareem Salam, how you doing there, brother?
All right, all right. Good afternoon, gentlemen. My brothers in medicine. My name is Dr. Kareem Latif Salam. I'm a board-certified adult and child and adolescent psychiatrist, medical director of adolescent services in a hospital in Northeast Philadelphia, and a founding member of Global Health Psychiatry, a collection of Black psychiatrists who publish mental health literature for the Black community. It's an absolute delight to be here, and pretty soon we'll be wishing everyone Merry Holidays. So take care and stay safe, and delighted to be here for this webinar.
Excellent, excellent. All righty. So I'd like to thank OBHealthy for allowing us to bring this webinar to you. Thank you for letting us use their platform so that we can do this for the public. All righty. So what I'd like to do, and the format will change just a little bit today. We had a PowerPoint presentation of the experiences that we had during the medical mission. And that medical mission was in Guyana. It was awesome. It was fantastic. It was amazing, wonderful. I don't know how many things I can say about it, but it was great. So what we'll do is we will start the presentation. Please understand, during the presentation, you can still type in your questions. We will answer your questions for all the audience and with the physicians here. And let's get started. Let's see. Now, bear with me because my technology skills aren't the greatest. So let's see if we can bring this up. All right. All righty. I'm going to see if I can do this. Bear with me, everyone. Let me know if you can see what I see. And I'm trying to right now bring up the slideshow. Hold on for a second. I'm going to stop that and I'm going to bring it up again. All righty. Are we good? Can you see it?
Yes.
Let me know. All righty.
We're good.
All right. Okay, here we go. So, and it was in Guyana that we did the medical mission, and we're thankful that we're here to be able to present it to you. All right, so let me talk to you and tell you a little bit about Guyana Medical Mission. Dedicated, and I'm just going to read, this is from their website, and it's excellent. Dedicated, dedication, care, empathy, education regarding one's personal care, and portability of medical care for all children and adults in Guyana. And it's interesting because each year they go there and they service so many people. In 2019, it was 4,436 people that they serviced. And these are lives that they took care of, and it's so, so great. They state, we appreciate your support as we continue to be of service to the people in various communities, and this is as they visit annually. And understand that this is an organization that goes out and does this for free. So if you would like to donate to this organization, I think they're so appropriate. You can go to their website and find the donation abilities or do it through that. And Dr. Court will talk about that as we go forth. The first slide I would like to say is I just want to say that it was a wonderful trip, and it was so important to us that Dr. Court and Audrey Fredericks Edwards, and the fact that they were able to put this together, this trip together in such an excellent fashion. Everything was top. You know, the work that was done to put this together was wonderful. And I'd like to just acknowledge it for a successful health mission. This is the team, this is some of the team as we came into the airport, and we were arriving and very, very thankful to get there and just overwhelmed and overjoyed. You know, we talk about Guyana and it's a country, and where is Guyana? Just to make sure that everyone knows. Guyana is in South America, and it's next to, as you see, it's next to Venezuela and Brazil. And we flew into Georgetown, and from Georgetown, we went to New Amsterdam, and most of the population lives along the coast. So just to give you an understanding of where the country is that we were. All right.
It's a little piece of trivial there, Omar.
All right, go ahead.
It is the only English-speaking country in South America.
Excellent. Yeah, I didn't know that. All righty. So, and welcoming, and these are just some beginning slides, and I'm going to let Dr. Court take over in a minute. There's a welcome to Guyana, and we were leaving the airport, as you see the airport in the background, and then going towards, an area towards a hotel and looking at the scenery. It's a beautiful country. And so we will continue. And Dr. Court, I'm going to let you take it from here. This is our welcome lunch. Once we got there, it was at the Grand Coastal Hotel. Dr. Court, can you give us some information as to the background of the Guyana Medical Mission, some of the things that came together such that it happened and that it is happening? Give us some understanding of what it's all about.
In 2005, Guyana government invited us to visit Guyana. It was after they had a flood. But myself and Dr. Saunders actually started this project. Dr. Saunders was my friend. We started going to Guyana because we felt that our country was not well served by our sister organization, Caribbean Medical Mission, of which we were a part of. Also, subsequently, we formed the Guyana Medical Mission, and we now partner with Guyana Medical Relief located in California, and we still have an affiliation with the Caribbean Medical Mission. This man, Saunders, he was awesome. I met him along the way. He subsequently got sick. And I vividly remember on his last visit to Guyana, which was in 2015, I have a memory of him in the hotel as he was in severe pain from his illness. He subsequently came back to America. And from then onwards, he had several health challenges. Subsequently, he passed away. At his funeral, I happened to have to walk in with the ministerial staff. And sometimes people kid me saying that, I'm now a minister, or I'm preaching and whatnot. But, this man really, really impressed me. I even went on the plane with him. I was in coach, while his body was in cargo. And as I watched his casket being lowered into his mother's tomb, I made a vow to him that we will continue. You see, we started just the two of us. We always wanted to be incorporated. And along the lines, subsequently, we met Audrey Edwards. And I'm happy to say right now we're all incorporated. And I'm proud to say that from a team of 2, the last time we went to Guyana, we were 58 souls who left this country. As you see, the arrival at the airport, and then we would normally proceed down to other areas in Guyana for the rest of our mission. Along the way, before I proceed, I have to acknowledge a few people because without them, this mission would not be possible. Our wonderful liaison, Mr. Clinton Williams, he's our Guyana connection. He makes sure that whatever we do, it's authorized by the government and the ministry. He's also helped by Miss Esther Lewis, who's the manager of his company. In addition to that, there's another person, her name is Michelle. Without her, all the drugs and medication that we send to Guyana will not be distributed because the day before we arrive, we utilize that day to get our medicines all sorted out. I also acknowledge my friend, Dr. Luncheon. I met him, I guess, 40 years ago at Howard University. And I have to acknowledge the ministers, the Minister of Health, Dr. Anthony, Dr. Ramsamy, Dr. Ramsaran, Dr. Sharma, Dr. Bob, Dr. Rampasad, and Dr. Albu. In addition, we met a wonderful doctor who was with us for the first time, Dr. Griffin. She was able to make things better for us, make it easy for us. And so, and not to mention my crew, without them, this would not be possible. So from now on, our show begins.
All right.
The first stop, see, when we go to Guyana, we always welcome our crew. And the first stop was at a place along the east coast of Demerara. We were at Grand Coastal Hotel. And these pictures that you see here are members of our team having a sumptuous lunch/breakfast. These are some of the members of our team. Next picture.
I just had to, Dr. Cord, I just had to show how beautiful some of the sunsets and sunrises were when we were there. It's just a beautiful country.
Along the way, see, all of our team, when we go to Guyana, we all go up to Berbice. See, Guyana has 3 counties: Essequibo, Demerara, and Berbice. And most of our work that we do is confined to Berbice and Demerara. Guyana is divided into 10 regions, and we primarily work in Region 6, Region 5, and Region 4. On the left would be Little Rock Suites. That's where most of the surgeons and the rest of the team that are in New Amsterdam, that's where they stay. And on the right would be Regency Suites, where the medical team leaves Berbice on Tuesday, and they arrive in Georgetown, where we are welcome at this hotel. And for the rest of our stay, we service Region 4, which includes ultimately the city, Georgetown.
Is there a specific reason why you go to those regions? Is that healthcare is not as prevalent there, Dr. Cord?
Well, sort of, but the reason myself and Dr. Saunders started was patients from my office and his office encouraged us. They said, why don't you guys go visit our area? And in order for us to do that, the patients and people from over here, they have to raise the funds to buy the medications. So this is why we go to those areas. For example, in Region 6, that's my village. That's the village that actually started this all. So, and there are other villages, and they raise the funds to buy the drugs so that we can go to those villages. We must mention that whenever we choose a village, it's not confined to those people from that village. Anyone throughout the whole of Guyana can come to those villages to receive health care. And the health care is free.
All righty. All right. All right.
These are medications that we mailed from United States. These go to Guyana. These are some of the guys that are on some of the boxes. I must add that throughout the year, we always send medication and other supplies to Guyana. Actually, this year we have already started. We did 1 shipment last Saturday. So these go by boat or sometimes by plane, and then when you get there, it's kind of a task, but well, we make it. We make it.
Mm-hmm. Excellent. Excellent.
This is our timetable. This is our mission. You can see we start from Sunday. We usually go to 2 sites each day, Group 1 and Group 2. And these are some of the other sites that we go to. And again, not because these villages and towns are listed, anyone from Guyana can come to those areas. This is our medical team. We also have a surgical team. They do their work at New Amsterdam Hospital, and Dr. Alves, who's the leader or the chief of the surgical team, he can fill you in terms of what we do or what has been done at New Amsterdam Hospital.
Right.
Well, from as Dr. Court mentioned, The mission has been going on for quite a few years. When I got involved from a surgical perspective, from the inception, what we tried to do really was to adopt a hospital. So the adaptation came with New Amsterdam Hospital. And once we got started, the objective there was a couple of things. One is to provide surgical care to not just folks in New Amsterdam, but throughout the country, as Dr. Court mentioned. And also to share our knowledge by working with the local surgeons at New Amsterdam Hospital, so that once we leave, we're leaving a staff that can take care of the community. I must say that over the years, I am so proud of the progress the local surgeons have made over the years. When we first started, laparoscopy was not something that they did often. At this point, they're doing quite a few laparoscopic procedures. And what does that mean? That means doing surgery with minimal incisions. And it's a very minimally invasive procedures without any big major incisions or scars. And we accomplish the same procedure as making the big incisions. The procedures that they're able to do laparoscopically at this point with her help, they're able to do primarily gallbladders, but they also do colons laparoscopically, colectomy or resection of the intestines. They also do laparoscopically tubal ligations. They do appendectomy. And I also think they've done a few hernias laparoscopically. So with the limited resources that they have there, I am ecstatic. I'm so proud of the progress they've made. And I must mention a few doctors, Dr. Algu, who is very impressive in many different respects. He has done extremely well over the years. We have seen tremendous progress in his technical and academic capability. And listen, I am honored to be part of the surgical program. The team that we have put together over the years, Dr. Kevin Clark, Dr. Patrick Anderson, the late Dr. Surishtani, the late Dr. Theophilus Lewis, or Theodore Lewis. I mean, these guys have all worked tremendously over the years to make this work. And on the average, this year we did 77 surgical cases, which consisted of a variety of procedures, GYN procedures, lots of general surgery procedures, which consist or included hernia repairs, gallbladders, surgical oncology, mastectomies, among other things. So overall, I think New Amsterdam Hospital has served us well, and we're so happy to be able to be part of that program. And as we go through the slides, we will see exactly what that entails in terms of our daily activity. And I'm sure Dr. Kevin Clark may have something to add.
Yep.
All righty, Dr. Clark, excuse me, Dr. Court, I just wanted to say that, we had, from a medical standpoint, there was 2 clinics per day, both clinics in different areas. And the amount of patients seen was, sometimes 250 to 300 patients a day. between the two clinics. So quite an impressive number of patients come out to see the be seen for medical care.
Not to be undone. I have to mention my girls. Over the years, I have mentored at least 7 young ladies who I remember when they came back from Cuba. And in terms of me working with them, these are very, very smart kids. And now I'm proud to say they're competent. They're able to treat medical conditions. As a matter of fact, last April, I usually go to my village on 2 occasions. They were able to see all the patients and they only asked me one question. They treated patients who had blood sugars of over 500 with normal saline and short-acting insulin. And we really, really did well. And I'm very impressed. As a matter of fact, one is now a cardiologist. Another one is a gastroenterologist. And I think she shared her experience with Dr. Ali at one while we were in Guyana. And the cardiologist worked also with Dr. Patel, who was gracious enough to give us one day. And on that day, they did 86 procedures at New Amsterdam Hospital. They did echocardiograms, including on children as well as adults.
Excellent, excellent. Yeah, and Dr. Patel came with us, yes. And it was interesting because he brought his children with him to experience the medical mission along with him as he did the echocardiograms. That was wonderful. Let's go to the next slide. All right. Now there was an interview, and sorry that my ugly picture came up, but there's an interview, and I'm going to run the video of the interview. Hopefully there's an issue pulling it down, but hopefully you'll be able to hear it. If we have technical difficulties, let me know and we will continue. But we're going to give it a try.
Hosted a medical outreach in New Amsterdam recently. A number of medical professionals from various specialties.
Are you receiving it appropriately, guys?
Yes.
Thank you.
Turn up the volume, please.
We're doing the best we can as far as the volume. I'm sorry.
It may be related to the way how it was downloaded. I think.
The site here, not just the starting medication, we give a 3-month supply of medication, and then we give everyone the clinic and be followed up with the clinic. And if there's any reason why they don't have the medication that we're able to prescribe for them, we can send it back for them. But the majority of the time, we prescribe medication and they can find locally, and we also have our eye specialists, our eye clinic, seeing our patients. We also have the pediatric patients who came in. We came in with the specialists. We have our eye specialists, stomach specialists. We have the OBHealthy, which is the women's health doctor. Dr. Omar specializes in pulmonary care and nutrition.
It's hard to follow it, Omar.
It's not coming through.
Yeah, it's hard to hear.
Yeah, the volume is very low.
Yeah.
Well,
Can I ask a question?
Sure,
As the video's playing, there are many difficulties with medical missions. And as I was watching this, the medical team sees a lot of patients over the course and over the years. And when you treat in medical conditions, it's a little bit different from surgery, where our results are a little bit more instantaneous, and we tend not to have recurrences, or at least the problem hopefully is fixed with one intervention. Medical problems, as you know, take a long time sometimes, and sometimes require additional management. Do we have follow-up? I mean, it's hard after we leave.
go ahead, Ken.
And also, I'm sure we see some of the same patients every year. So what's kind of, are we seeing any progress in the patients that we have seen over the years? And what sort of follow-up do we have after we leave?
Can answer that, Dr. Court. What we do at my village, we have our own files, our own charts, and you can go to any patient X, and check his records to see what his or her blood pressure was 10 years ago, or even up to 15 years ago, and follow that patient. And you would see, yes, they do come back. Also, we have a mechanism at our village where whenever we are there and we have medications left over, the patients can come. I think they come once every Wednesday to get refills. And what the nurse will do will pull that chart, see what he was treated with, and refill the medications. And this goes on until all the medications are done. What we are hoping to do for every site is to have a system like that. Another site is, they're almost close to being like we are at Firish, but it's a work in progress. But our aim is to have those charts ready every time the patients come, and most of them do come back indeed.
Excellent. All righty. So we're going to continue, and I'll go through some of these slides. This was the group, and we're up at 7 o'clock each morning, ready to go, and we go to the clinics at that particular point, and happy and ready to go. Once we get to the clinics, the patients are usually there waiting, believe it or not. 7 in the morning, there are patients waiting outside, inside, and when we get there, the patients are assessed, and well, let's go through the further slides and we'll see. But this was the first clinic, and Dr. Court, you can talk about Berbice as being our first clinic and how we assess the patients and work them up.
Okay, this was our first day, the Sunday, and it's at my old high school. When I was a little urchin, that's where I went to high school after common entrance, I guess. So it brought back memories. Of course, the school was not as large as this. The auditorium certainly was not as large, but these are patients who are waiting. And this gentleman here, he's part of our group, and he's the point person for New Amsterdam. And these on the right are patients being assessed, having their blood pressures done, and there are nurses there who can do the vital signs, then they send the patients on to the medical team.
Excellent.
But can you guys, it's probably going to be similar at most locations, but can you guys just outline how you set it up? So there are different stations.
Yeah, well, I'm going to go, I'll go through that, Kevin. And
Okay.
basically, when the patients first get there, they go into intake, and basically they're triaged in a sense that they do blood pressures, they do blood sugars, they do height, they do weight, and you see Lennox there. He's evaluating the patient to understand where he was one of the nurses evaluating the patient to understand where they should go next. Mr. Lambert, the lab technician, he was doing blood sugars. They do the pulse ox to see what the oxygen is. All of those things are assessed. Let me go with one more. So this is what this was a triage station at one of the locations that they set up. And you understand, Dr. Court, they set this up such that it's almost like a mass unit. You come in, you're assessed, you're triaged, and then the patient goes from there to see the doctor. And from there, it goes to pharmacy and then and appropriate follow-up. So we do the pulse oximeter, which is the oxygen in your blood to understand whether you're having an appropriate amount delivered to your heart and the rest of your system. You have your heart rate taken, the finger stick blood sugar was taken, the blood pressure, your weight, as well as your height was taken, and then you move on to the physician. to appropriately, the appropriate physician. If it's a breathing problem, then they tried to gear it towards the pulmonologist. If it was a stomach problem or a GI problem, they tried to gear it towards Dr. Ali, the gastroenterologist, or the internal medicine. So it was very well put together, and as far as directing the patients. You had any more questions, Kevin?
Yeah,
And if
I have-
there's a surgical problem,
Wait, I have to say something in terms of our medical, then I'll let Lennox do. We have in our group 3 drill sergeants. We have names for them, which I wouldn't mention, but I've never seen some people who could organize that chaos that we see in the morning, and within a couple of minutes, 15 minutes, we're ready to go.
Yes.
One is pictured right there now, and the other 2, they work with team 2.
Yes, yes, yes,
And
they
I-
were
Have
excellent.
names for them. We wouldn't mention those names.
Omar, I would just add that if any surgical issues arise, then you guys will send them back to New Amsterdam Hospital so that we can try and accommodate them on the schedule.
Mhm.
So, we get a lot accomplished throughout this entire mission.
Yeah, yeah. We have a picture coming up of one person that came to one of the clinics, and it was one of the earlier days, orthopedic patient. And we'll talk about that. We have some pictures to show of that particular patient. All righty. So as this is just stating that, each morning we were there ready to see the patients. It's interesting, but Dr. Court, you always seem to be the first one there. By the time the group gets there, you're already there seeing patients. So
Yes, that's true.
that is true. He was the first
Yeah.
one to get started and the last one to stop. So
That's
I'm
correct.
always impressed, always impressed. But do you have anything to say, Dr. Court, in any of the type of problems that you saw and how you handled them as far as internal medicine was concerned?
Well, the most important ones are the patients with very high blood sugars. This year we had patients with blood sugars over 600. The machine will not measure anything else, and we're able to treat them, hydrate them, give them short-acting insulin, and control their blood sugars. In addition to the usual very, very high blood pressures, because in Guyana, as the same occurs over here, people are only sick when they're in pain, not realizing there are other things that are killing you that doesn't produce any pain. They're only pain and they're only sick when they're in pain. If they're not in pain, they don't come.
Yeah, I agree, Dr. Court. And while there, the blood pressure as well as the diabetes and the blood sugars were very high. Coming in, we had blood pressures coming in over 200, where we would have to give, very fast acting antihypertensive or medications for the blood pressure, and then monitor to make sure that the blood pressure came down before the patients left. Same with the insulin given to the high sugars. We would give that, we would put an IV in, give the patient fluids, and try to get that blood sugar down, and monitor that patient to make sure that it was in an appropriate range before they left. So the type of medical care that was done, and once you got there and set up in the clinics, was amazing. It was almost like we set up a hospital to take care of these patients. And truly, there were patients that we had to send to the hospital for acute care because the conditions were not appropriate for that type of care, and the blood pressure or the blood sugar was just that high. All righty. Now, this is day 2. We went to Rose Hall, and as you see, patients were waiting. I'm going to keep going here. As far as we talked about the diabetes and the hypertension, and it was real. The high blood pressure, it got to a point, and I'm going to be very honest with you, where it was thankful or unusual, put it this way, to see someone come in with normal blood pressure. Most patients were being started that I saw were being started on antihypertensive medications or some type of diabetic medication. Dr. Court, was that your experience as well?
Absolutely, yes, true, very true.
Yeah. So you know, and you really try to figure out why so many people had high blood pressure and diabetes. I had several patients that had associated strokes in the past because of the high blood pressure. And, you know, you try to figure out whether it's their diet or if it's, you know, exactly why so many people you know, are in that situation of needing medical care and not realizing that what's happening in their body can be you know, very, very harmful going, you know, from a medical standpoint. Yeah. This is Dr. Hazel Nurse, and she was there with us. She's treating blood pressure. This is, you know, and this number is not uncommon. 210 over 1/8, not uncommon. But understand when someone has that type of blood pressure, the likelihood that they can have a stroke is really there. So you really want to get that blood pressure down. So as stated before, we gave stat medications to bring that blood pressure down and observe the patient to make sure that they didn't the blood pressure doesn't come down too low and too fast, and that they're stable before they leave. Also, as far as diabetes, serious disease, same thing, doing blood sugars, and once you note that the blood sugar is that high, to truly give that insulin and monitor appropriately. And as you see, the team is doing a yeoman's job there. Okay, it would be nice if Dr. Reynolds was a part of us, but Dr. Court, can you talk about Dr. Reynolds a little bit, our pediatrician?
Can I ask a quick question before we go into that?
You sure may, and I'm so thankful, Dr. Salam, that you're here and that you're able to ask these questions. Go ahead, brother.
So I think this is probably for Dr. Court. What technology were you using to monitor the blood sugars of the folks receiving the IVs and the fast-acting insulin? How are you tracking those blood sugars over time?
We would have the patients get their blood drawn, say half an hour and an hour after we started the short-acting insulin.
Okay, so you were drawing tubes of blood or doing AccuChecks?
AccuChecks, finger sticks, finger
Just
sticks.
finger stick. Okay.
Yeah, that was the thing. See, you understand, and I'm sure you know, Dr. Salam, each patient is different. So some patients, you know, you'll give them medication and their blood pressure will go down really quick and really fast, and another one, you know, may not. So the most important thing is that it came down into a safe range. You don't want them going home too low, and you don't want them going home if the medication hasn't worked at all. You know, so we tried to monitor.
For the blood sugars, we try to have them be around 200 or high 100s rather than 100 or so.
So it's
And also,
like,
may I
it's
add
like that. It's like that rule of thumb for a hospitalized patient, even in a psychiatric hospital. You know, 200 or below is acceptable for blood sugar, especially for someone in the hospital.
Yeah. Mm-hmm.
And may I add that the
Go
clinics,
ahead. Go ahead.
we were able to also provide medications that would, so we would bring down the acute situation, but then the other important part of it is the long-term effects, right? So, and that's where we prevent the longer-term complications. So the clinics were able to provide patients with a supply of medications to take home, in addition to that education, so it would prevent the problem from happening again.
Yeah. Excellent.
Well,
And we're going to talk about pharmacy. Go ahead. I'm sorry. I didn't mean to cut in.
What we do is we try to give the patients 3 months supply of medications. For whatever, you know, blood pressure and diabetes. That's what we do.
Yeah. All righty. Dr. Court, can you talk about Dr. Reynolds?
What a man. You talk about me starting early. Yes, I did. But Dr. Reynolds, he leaves late. He never leaves any site with us generally because he's dedicated. He loves what he does. And as far as he is concerned, just like us, each patient has to be seen. He's been with us for years and years. I don't remember how long, but he's always there. And he's noted that we sometimes wait for him, other times he finds his way to the next site.
Yeah.
and
Dr. Court,
dedicated pediatrician.
Dr. Court, if I can ask a question about the medicines. Two questions. One is the type of medicines given. If the patients happen to run out of medicines, can they get similar medicines in Guyana at the local pharmacy, or are they allowed to go back to the various sites? And do we have medicines there that can bridge them until the team returns?
Very good question. Doctor, what we take to Guyana, when we first started it, myself and Dr. Saunders, we got a formulary of what is used in Guyana. So every medication that we take here is available in Guyana. And the medicine that we take to Guyana, the expiration dates are usually 2 or 3 years from the date. So again, we use the same medicine here that is used and that are used in Guyana. Same metformin, same glipizide, same whichever.
Mhm.
It's the same medication.
Right.
Very good.
And that's
So
important.
so they can buy it at a local pharmacy if they want, because you know how the system in the third world countries work. You can go to that Punai's drugstore and get the same thing.
Right, right.
Yes,
And-
we do.
Yeah, and it's encouraged for the patients once seen by us and get by the physician, I should say, and they get their 3-month supply of whatever is prescribed, that they can come back to that clinic as well and see the doctor that the Guyanese doctor or the doctor who's there and follow up so that they can continue to get the medication. And it's encouraged for them to come back to the clinic, not just go to the pharmacy, but to come back to the clinic and be followed appropriately.
And again, what medicine we don't use on that day is left right at that clinic. We don't take it to another clinic. Each site has their own medication.
Excellent, excellent. I would say Dr. Reynolds, and you're right, Dr. Court, Dr. Reynolds is amazing. There was one day when the clinic was next to a school, and when the school let out, all of the kids came over to the clinic. And he was there till about, I understand, about 10 o'clock at night, seeing all of the children to make sure that all the children were seen before he left. So what an amazing guy. And just a wonderful, wonderful person. All righty. This is just letting you know there was one unhappy customer and trying to take care of him, but he was not happy about that. All right. So now, Dr. Alves, we're going to go into surgery a little bit. I wanted to know, let's see, and we will get to, I know that there's some questions, and we will get to answer the questions if people type in questions outside. And as far as the physicians are concerned, continue to ask your questions. The questions are excellent. Dr. Alves, we're going to start with surgery now. So surgery occurred at the New Amsterdam Hospital. And there we had the GMM surgery as well as GMM cardiology. And I'm just going to start into the
As I previously mentioned, New Amsterdam Hospital, that's our anchor. When you look at sizes of hospitals in Guyana, New Amsterdam Hospital is the second largest hospital. So it was a good idea for us to make that our anchoring hospital. So we generally will get a list of patients who are in need of surgery. That list usually come to Guyana Medical Mission. I would say, and correct me if I'm wrong, Dr. Court, I would say sometime, be it July to August,
Correct.
of the year that we plan on going to Guyana.
Mhm.
So on that list, it will clearly state what the patient's ailments are, what their surgical issues are. So we have an idea as to what to take, how many meshes to take for hernia repair, whether or not we need to take other technologies so we can do, be it cholecystectomy or gallbladder removal, so that we can do GI surgery, Dr. Kevin Clark. so that we can, if they need a stapler, for example, so we can do a joint or an anastomosis, it gives us a lead time whereby we can work with the folks here, that is the pharmaceutical companies. And I must say, these guys are very generous here. Once you give them heads up, they will do their best to get you what you need so that we can perform the surgery efficiently and safely.
Excellent, excellent. All righty. So these are some of our surgeons. I know you have Dr. Kevin Clark here and Dr. Patrick Anderson. Dr. Sahota is he's the head of anesthesia
Correct.
of the group, and so happy to have him because his skills are enormous as far as that's concerned. And we will have some pictures of him going forward.
And I must say, anesthesiology or anesthesiologists, they're in a great demand, not just in Guyana, but here. We have a problem here also. There is a significant shortage of anesthesiologists. So we were happy that Dr. Sahota was able to bring his team. He had 3, if I'm not mistaken, 3 nurse anesthetists or CRNAs with him. And that made a tremendous difference in terms of us managing the operating room. So we were able to do the 77 cases, quite efficiently.
Excellent.
One of the things with surgery, as you go on and show the rest of the pictures, you have to understand what the disease processes are there, what your capabilities are, and what you should and shouldn't do in that location. And that's something that we always discuss. We'll see patients sometimes with advanced or very complicated issues, things that would be difficult to tackle here, that would be even more of a challenge there. And the goal is to help, but you also want to make sure that we're not in situations where we can't accomplish what we should be able to accomplish. And that's always with all missions that you do, that's always one of the big challenges.
Kevin, I think that's a very important point, because at the end of the day, you want to make folks better, and you want to come back, you want to leave with that feeling of gratification, knowing that your patient will be okay at the end of the day, and
Right.
you don't want to make them worse. So I think that patient selection, it is so important, and that's a very good point.
So the pictures you have here, this is actually our last case on Friday as we're getting ready to pack up. And this lady walks into the emergency room probably around 1, 2 o'clock in the afternoon. And being there for the week, the emergency physicians have gotten to know the team. So they felt comfortable coming in and getting one of us to come to the emergency room and look at this lady. She came in because she actually passed out and one of her neighbors brought her in. And in trying to figure out the reason why she passed out, on examining her, she had, you can't really see it clearly here, but a large fungated left breast cancer. She was very reluctant to stay to get treated because she was concerned. She has a relative that she's taking care of who has a broken hip. So she's compromised and she's taking care of somebody else who's also severely compromised. But we convinced her to stay. And the reason why it's a semi-emergent or thing that we felt we needed to do at the time is because she's bleeding from this. It's a combination of an infection and blood loss. And over time, I think her hemoglobin was about 6 or 7. So it's an issue where over time she will eventually either have a heart attack or have some complication related to anemia. So we ended up doing this procedure here as our very last case. And you can see myself and Dr. Anderson on the right and on the left. The gentleman that you see to the far left is actually Dr. Gorin, and he's the orthopedic surgeon. And we'll talk about why he's in the picture. And then the other folks, this is the GMO, which is the general medical officer, which is one of the residents in the program in Guyana, and then the nurse. Dr. Gorin scrubbed in. It's too bad he's not on the call, but he took the opportunity to scrub into both the GYN cases, the orthopedic cases, the urology cases, as well as the general surgery cases. You go to the next slide.
This is our urologist, Dr. Scott, and he's not with us either, but Kevin, maybe you can talk about some of the things that he did as far as some of the procedures.
So this patient, interestingly, and I started going on the trip maybe 4 years ago. And this gentleman has been, the patient they're operating on has been a complicated patient. So he was involved in a car accident and had a major pelvic fracture and had disruption of the tube that goes from his penis to the bladder, the urethra. And it wasn't repaired acutely. So he had the connection was actually lost, or at least not intact. So he had what they call a suprapubic tube. So instead of the urine coming through the normal way, they had to put a tube directly into his bladder. And this gentleman, I think, is very young, is in his 20s. So there's a series of operations to try to restore continuity. And I know Dr. Scott has been working with this gentleman for the last couple of years. He has a very tight stricture there. And I think, I don't know all the full details, but they were trying to see if they can get to see the connection. And the procedure that he's doing there is called a cystoscopy, where you put a camera through the penis and try to get a look into the bladder. And here it was so tight that they weren't able to actually see or get beyond that area. I suspect this guy actually is going to be an ongoing problem. He's going to need to have something major done to reconstruct that area.
Right. All righty. And this is Dr. Sahota.
So
And
Dr.
Sahota,
Sahota.
yeah.
So one of the things that we did this year, so in addition to providing anesthesia, he has a pain clinic. He's a pain specialist. So we had several folks come in with radiculopathy and other sorts of chronic pain ailments, where he's able to do local nerve blocks. So these were epidurals that he replaced. I think this was a shoulder block for this patient, but several other patients with back pain, he performed epidurals.
Mm-hmm. And understand, and from the medical standpoint, back pain was a very, very common complaint when we would see the patients. The high blood pressure, the diabetes, back pain, and vision was very, very common as well. And believe it or not, and Dr. Ali will talk about this, stomach pain, esophageal reflux, and things like that were very, very common. Yeah.
So the nerve blocks, so this was a new service that we decided, or at least I think he had spoken to you, Dr. Court, that we were going to offer for this year.
Yes, he did.
Mm-hmm. Yeah.
Yeah, Omar, if I might say something, I just want to apologize for getting here late. Yeah, I was stuck in the hospital.
Well, welcome, Dr. Anderson.
Yeah. I think, some of the common things that we see, the chronic back pain, the shoulder pain, the hernias, and anemia secondary to chronic blood loss in women with fibroids and prolonged menstrual cycle relating to fibroids. The Guyanese society is a laboring society. Many of these people folks. They work in the fields, they walk to where they go, they carry their bags from the grocery store. So, you know, it's not surprising that a lot of the hernias that Dr. Alves and Clark and the other surgeons see and myself work with, some of them even incisional hernias from prior operations, is because of, you know, long-standing heavy lifting, you know, and just the fact that they're a labor force. So it's often debilitating, for example, when a lady tries to work or walk with a hemoglobin of 5 or 6. So, you know, repairing these hernias, you know, alleviating some of these joint pains, even if it's for a short period of time, is really a significant input into their daily function. So, you know, doing these kind of operations were very necessary. I think some of the inguinal stuff that Dr. Alves does with the plug patch and plug technique that he uses quite quick. So, you know, he's able to do a lot of them over a short period of time. And we go back the next year and we see even young kids coming in and say, Doc, look, I can dance now, because they couldn't dance before because they have these hernias. So, you know, it's a really, really gratifying to go back and see folks, you know, coming back and telling you that, you know, now I can work and walk without, you know, much symptom.
Good point. Also, if I may add one other thing, Pat, you know, over the years, we always have to time things in such a way that if the guys are working on their estates, they don't want their hernia fixed, because that interfere with their ability to work. So generally, we try to coordinate things in such a way that they can heal properly before they go back to their estate, the cane estate.
I have a question. These folks with the low hemoglobins of 6, 5, 6, 7, and at risk for anemia with the chronic blood loss, were they being transfused? How was this blood loss managed?
It's managed based on symptom. So oftentimes they'll go to the emergency department, and maybe all they get is hydration because the blood may not be available. There are a few cases that we wanted to do, and myomectomies, for example, in young patients who were not only anemic but was trying to retain fertility. You know, the conundrum is, do we transfer them to Georgetown and hope they get on a list in a timely way, or do they have the resources in the Region 6 where we were to do an operation and to be able to transfuse if we have surgical blood loss? So oftentimes blood is not always available, and when it is, they have to ration it based on, you know, what they anticipate might come into the hospital, such as car accidents, maternal hemorrhages, those kind of conditions.
This is absolutely fascinating, just hearing the logistics behind practicing medicine, just you know, in this climate. It's just something we're not used to in the United States. And it's almost like we take for granted the luxuries we have here. So this is pretty incredible to hear. And while I have the mic, I have a question about the kids. Were the kids being vaccinated according to American standards? Were vaccines provided to the kids that were seen?
Dr. Court, maybe you can give us some indication of that?
No, we don't, but Guyana has a very active vaccination program. Even when we were there, the vaccinations are usually done at the health centers and probably at the hospital, but I know for sure that they're done at the health centers.
Okay, so that's not a service provided by the mission.
No.
No. You know, the thing of it is I remember one patient we were, and it was the last day that we were there. And at the end of the day, and a lady came in, and she came in with her blood work, and she had been to the hospital, and she had fibroids, and she had her hemoglobin, and her hemoglobin was like 6, 5.96. And she came because she heard that the doctors were there, and she wanted to know if she had surgery. And it was our last day. Believe it or not, the clinic was ending, and she was trying to tell us that she was going to wait until next year
Yeah.
when we come back, and we were trying to convince her that this is a situation you cannot wait till next year. You have to go back to the hospital in Georgetown and go to the clinic and be evaluated appropriately. They've already started it and have the surgery. So she wanted to wait the whole year for us to come back, and I'm like, this is not appropriate. You can't do that. You have to go back. That's just one story of many that we had like that. Okay, surgical hands, Dr. Anderson or Dr. Clark. I'm sure you were in on this case.
I'm gonna let Dr. Alves comment, because he's doing a hernia repair with the GMO Hamilton there.
Right.
And yes, it's an open, it looks like an umbilical hernia repair, and that's just an opening. Let me just say, a hernia by definition is an opening in the fascia. So that opening or that hole has to be fixed. And there are many ways of pulling it together or fixing it. I mean, we can do it primarily by pulling the tissues together, or we can do what's called a no tension technique, in which we bridge it with a piece of synthetic material or mesh. And in this particular case, I think that's what we did. We were able to bridge it so that we get a stronger repair with a lower rate of recurrence. And as Dr.
I think we lost Dr. Alves.
Yeah, I think he'll come. Hopefully, he'll come back.
I think
Yeah.
what's important in that picture is he's working with the local staff, and that's one of the things. Even though we do bring residents with us, it's very important that we work with the local staff there to help train them, and that's an emphasis that we always have.
Right, right.
Could one of the surgeons define a lap chole for our audience?
Oh yeah,
I'm gonna have Dr. Alves do that too.
Dr. Alves, can you
Can
define lap chole for us?
Absolutely. Can you hear me or?
Yes, we
We can
can
hear you
now.
now.
We lost you for a minute, but we can hear you now.
Yeah.
Do we have a
Yeah.
picture of that, Omar?
A lap chole? Yeah, we do. Hold on for a second. Oh, it's in the other. We'll get to that, but you can
Okay.
define it. But we'll note it when surgery comes up twice. So
Okay.
we'll get to that.
As I was saying about this particular case, can you guys hear me now?
Yeah, we
can.
can hear you. Yep.
Yeah.
Yes. I said a hernia by definition is a hole or an opening in the abdominal wall in this particular case. And the objective is to bring the ends of that hole together. And there are a couple of ways of doing it. You can use the tissue primarily to bring it together, or sometimes we do what's called a no tension technique, in which we bridge it with synthetic material, whereby we can get a stronger repair and less recurrence. And that's what I did here with the local surgeon.
Yeah. All righty. Dr. Salam, we're gonna come to a case that is an actual lap chole, and I apologize, I mislabeled this slide because it was a hernia, but we're gonna come to a lap chole.
Yeah,
And
but
we'll-
I don't think the audience understands the terminology.
That's what I know, and
Sure.
when we get to that picture, we'll explain. All right. Okay. All right, but we're gonna go back to medical clinics just for a minute. All righty. So, and this is Dr. Court. This is another clinic that we went to. This was day 4. Is Dr. Court with us?
Yes, this actually is Dr. Alves' village.
This is my village, yes.
Yes,
All righty.
But I'm going to have Dr. Court do the narration because, yes, this is my village, but he did the medical aspect of things, and for which I'm grateful, and the entire Mahikans are grateful. So my family members can't stop thanking you guys. So Dr. Court, why don't you take it away?
Well, to the left is one of our drill sergeants, just the one that really gets us going. It's by, actually, they come after I've been there and I try to organize, but I'm not as good as Sharon. So So we just arrived and there are people waiting for us. It's a smaller site, but it's throughout the day, there are people coming in all the time. At this site, we would also do vision, and I think vision is coming up just now soon.
Yeah.
The- yeah.
Can you say something about Mama Joyce?
Oh,
Please.
how
Please,
could we not? How could we not? Mama Joyce is known as a global person, a global eye person. I think she participates also in Caribbean Medical Mission. And I don't know how many countries she has been to in terms of eyes. She's our main eye person. I wish Dr. Cunningham, he was here so he could tell you what an asset she is in terms of whatever she does. As a matter of fact, remember, I normally go to Guyana a couple of days before to make sure that everything is ready. Mama Joyce is always there because what we do is just give her all the eyeglass things and she takes care of them. She goes home and she separates them into each village. And what else can I say? Thank you, Mama Joyce.
Yes.
Thank you so much.
I hope you guys noticed we didn't call her Miss Joyce or Mrs. whatever her last name might be. We call her Mama Joyce. You know,
Mama.
she is entrenched in the. I've been watching this lady for about 10 years, and it seemed like every village she goes to, someone knows her very, very intimately. This lady.
The amount of people she's helped is enormous. So, yes, thank you. All right, so just stating again, anytime we go, the patients are waiting, and this is a slide that I must state that Janine, the nurse practitioner, she worked alongside of me, and let me tell you, she was great. Oh, we saw so many patients, and I mean, she picked up so many excellent diagnoses and treated them appropriately. She was excellent. She's a nurse practitioner at Newark, Israel, and work in the cardiac unit. And let me tell you, she was right. She kept up with me, and I was very impressed, and so glad that she was part of our team. Yes.
And she's telling her friends when she got back here how good it was, and she's actually started to recruit people for us next year.
Let me tell you, she was excellent. And if she's watching, thumbs up. You were great. All righty. Okay. So as far as our ophthalmologists are concerned, Dr. Court,
Can we go back to the previous slide and
Sure.
say something about Tricia, also who's a nurse practitioner?
Oh, all righty.
That's
Yeah.
our drill sergeant.
Okay.
One of our drill sergeants.
Okay.
All righty. All right. See, you understand I was part of team one, and she was part of team two.
Okay.
So I didn't get a chance to meet her, or put it this way, I met her, but I didn't get a chance to work with her. Now, Dr. Court,
And you can't say Tricia without Joan.
say that
That's
again.
right.
We know Tricia without Joan. So Joan
Is
is
that Joan
our
right next
other.
door?
Joan is our other drill sergeant.
I got you. All righty. So, Dr. Court, can you say something about our ophthalmologist?
Yes. This year we were lucky to have 3 ophthalmologists, and this is the first time they're joining our team. One is Guyanese, but she was physically in Jamaica, and she was able to recruit 2 others because we were kind of short on ophthalmologists. So we are grateful for your assistance, and hopefully you'll become a permanent member of our team.
Yeah. Well, I'm telling you, just about 90% of the patients that I saw wanted to see the eye specialist.
Yes.
Believe it or not. And Dr. Ali, I mean, did you have that same type of experience?
I agree. And, they really needed it. I mean, the services that they provided were incredible. And the patients were just so grateful for it.
Yeah.
Omar, sometimes you have to also put this into context, going back a few years and hearing the stories. I remember Dr. House, maybe 4 or 5 years ago, we were up at Friarish, and an older gentleman came up to Dr. Cunningham, and I guess he had refracted him a few years ago, and he said,
Now I
Doc,
can see.
my eyes are so good now I can see to text. I thought he
That's
would say
right.
he could see to read his Bible. This gentleman was happy he can see to send a text.
I hear you. I hear you. Great, great
Eyes are
story.
all this.
What were some of the common ophthalmologic problems that were seen?
Not sure, but they all need glasses. That's all
Yeah,
I can tell you.
glasses. It's a big thing.
And prior to seeing the ophthalmologist, the patients have to go through medical. Because if your blood sugar is very high and you get a pair of glasses, when your blood sugar comes down, it will be useless.
Yeah,
So they get 2 visits. Also, of course, we have to bring down the blood pressures.
Yeah, Dr. Salam, unfortunately, some of the problems that may cause the decreased vision, it's hard to work it up in a clinic type situation like this. And we encourage the patients to come back and, do what they can as far as that's concerned. But a lot of them want glasses. And the only pair of glasses that they have is the glasses that they got because the doctors had come at one particular time, and now they can see with them, and they want to make sure that, well, if they're broken or if they need repair at that particular point, But I'm sure that with diabetes and hypertension being such a significant problem, a lot of the problems with vision, glasses may help, but it won't correct the problem.
In addition to giving glasses, the doctors also give eye drops for whatever condition is appropriate,
Mhm.
like infections and or glaucoma, I think also.
All righty. All right. And this is me, of course. The slide on the left is a lady that came in and she had asthma. And she just wanted it checked and to evaluate, and she had this cute little baby with her. And so that is our commander in charge there holding the baby, and the patient actually is the lady on the far left. And then the other picture is just me checking the lady's heart and her lungs. Understand that some of the problems that we saw, and I'll give you an example. There was a young lady that came in and she complained that she had shortness of breath just walking across the room. And this lady, she was 19 years old, and she had no prior history of lung problems, no asthma, no wheezing, no family history of lung problems, no significant heart problems that she knew of anyway. But she was significantly short of breath while walking across the room. And evaluating her and listening to her and trying to figure out exactly what's going on. A young person basically just out of, pediatrics and having such significant shortness of breath. And listening to her, it was a classic murmur for mitral valve prolapse. And understanding that this can happen to young females, more common in young females where the valves are of the heart. The mitral valve of the heart is one of the valves that lets the blood go from one chamber to another who's not working appropriately. So we made sure and we got her over to the cardiologist. And these are some of the things that you pick up because, this young lady is basically, she doesn't go to the doctor, barely ever seen a doctor. And now all of a sudden she's so short of breath that she can't walk across the room. So listening to the hearts and lungs are very important. And when I can remember back in medical school, when they talked to us about evaluating a patient, there are 2 things that are very important. Number 1 is listening to the patient and hearing their story. But number 2, also to make sure that you understand what you're hearing when you do listen. And so very appropriate. And it was very gratifying to know that we could get some help with that young lady. All right. The food was excellent. Dr. Ali, you want to chime in on the food? It was great.
I was, yeah, everywhere we went, the hosts of the clinic were just so gracious. They prepared meals for us, snacks. They would oftentimes bring us something to drink. We have a slide, a few down where there was a gentleman that would make juices for us, and he brought in juices, and the food is, Guyanese cuisine. I'm obviously biased, growing up in a Guyanese home as well. This was my home food, and there's just nothing that can beat it. But as we'll talk about on the gastroenterology side of it, it does carry some consequences, especially because much of the cuisine carries a lot of spice, and that can have some effects with acid indigestion, things of that nature. But the food was absolutely incredible, and we had people that were so grateful for us to be there. I remember meeting a lady in her late 80s who brought me a tuna sandwich. And she walked like 2 or 3 miles from her home to the clinic, and she gave what she had, and it was just the thoughtfulness and the graciousness of the patients it's really the heart of Guyana and Guyanese people and our culture. But the food is just incredible. So for those who have never tried Guyanese food, I absolutely recommend it. And I'm biased. I think it's the best tasting Caribbean food that's out there.
Yes.
Excellent, excellent. All righty. So we go to Buxton. Dr. Court, can you tell us a little bit about Buxton?
One time they were rowdy, but this time they were really great. As a matter of fact, as usual, they all show up. Buxton is a site, when we go there, 200 people at least waiting for us. This was the only site where we only place where we had to do one site only, and the whole team had to be there because the numbers are always so large.
Yeah, excellent. Yeah, you're right about that. And Dr. Ali, I want to let you take these. This is your area.
Yeah, so this is my first year coming on this trip, and I wasn't sure what to exactly expect, but gastrointestinal pathology was quite significant. I would say we talked about diabetes, we talked about high blood pressure, and those were some issues. But the third, probably most common issue that we saw was gastroesophageal reflux or epigastric pain, dyspepsia, which is pain in the upper part of the belly. And a lot of times what it comes down to is, again, that delicious cuisine, but with that carrying some spices with it that could predispose people to have more acid reflux, things of that nature. So I did see a lot of patients who came in with abdominal pain, reflux, some lower GI related issues such as diarrhea or constipation. And what I also saw a lot of, or a fair amount of, but when patients would come in, would be a concern for an infection called Helicobacter pylori or H. pylori. This is an infection that we see across the globe, but it's very common in about 10 to 15% of patients who have H. pylori. They can have ulcers that can develop in the stomach as well. And as we were there, as I was grateful to have with me another gastroenterologist, Dr. Daniels, who's incredible.
One of my girls.
Yes. And she was able to actually help us in the sense of, I was able to actually order labs, order things, because again, we're here as partners and to supplement what's an existing system that she was able to help me navigate through. And so we were able to get some diagnostics on some of our people, treat them for underlying infections. And so I did feel that the GI need there it's truly there. And we were able to help a lot of folks who came in with these GI issues.
Dr. Ali, do they also refer to gastric reflux as burn stomach?
They burn stomach, or they use the term catch wind. Thinking catch wind, I thought, well, are you short of breath? But really, it comes down to reflux. So, yeah.
Excellent, excellent. I know as far as reflux is concerned, from a pulmonary standpoint, it's very significant as well. There are many patients that have shortness of breath secondary to reflux because once the acid comes up into the back of your throat, just a little drop, just little drops while you're sleeping, if it goes into the lung area and it goes down the airways, it burns the lung tissue. And when the lung tissue heals, it heals as a scar. And those scars over time prevent appropriate oxygenation and prevents the lungs from stretching and accepting the volume of the air that it should, so that you can get enough oxygen into your blood. So I do have patients that I follow that simply from esophageal reflux have shortness of breath. And once this shortness of breath occurs, there is no medication that I can take that scarring out of the lung. So it's very important to treat that esophageal reflux appropriately.
You know, there's 3 common causes for a cough, a chronic cough, when somebody
That's
comes in with a
right.
dry cough.
Mhm.
Asthma, some sort of allergies, an allergic rhinitis or post-nasal drip, but the third most common cause is reflux.
Reflux,
Right.
absolutely.
True.
Manifestation.
Yep, that is so true. All righty. So in talking about pharmacy, and as I stated before, Dr. Cord had stated, the patients get a 3-month supply of medication. So any prescription that we write, and even if they come in with a particular medication and they need a refill, and we didn't prescribe it, they will still get that 3-month supply before they leave the clinic. So that is so important. And the pharmacists, boy, they were busy. And the support staff helping the pharmacists. I mean, as you see, the medications are there and they're counting them out, and they're really busy all day long, because you can imagine 200 to 300 patients coming in and all need medications, different types of medications. They're busy all day long. Dr. Court, can you say anything about it?
No, this was at one site, so can you imagine how many people, how many other staff we need in addition to the pharmacist? No question about it, man.
Mm-hmm. True.
We
So
do need pharmacists.
yeah. I'm telling you, they worked hard. I would talk to the pharmacists after the end of the day, and they work hard. They all day long, they're busy. All righty. So Dr. Ali, this is your story here. Yes.
Yeah, so this gentleman, this was at the BV clinic in Berbice. And this is a gentleman who somewhere in his 20s had some sort of he had a traumatic injury, obviously requiring a left upper extremity, a left hand amputation. And despite that adversity, you know, his energy, his attitude towards life, and how much he's willing to help, it was just incredible. He owns a farm, and he's a farmer, and he grows fruits, vegetables, and his business is that he is a juicer, and he's a juicer for his village. And as a thank you, he came to our clinic and brought these incredible juices: golden apple, guava, and cherry juice. And he made these juices for us, and he just handed them out. And you know, he wouldn't accept a dime. He was just grateful that we were there, and I felt very privileged to just take care of him and chat with him and hear his story. And yeah, just an incredible human.
Yeah. And that second slide, always teaching. I mean, you seem to always be teaching. Whoever you came in contact with, you were teaching or telling them some great medical advice. So I was so impressed and and privileged. We worked together that first day before they
Yeah, I
snatched
loved it.
you away to team 2.
You know, I believe my philosophy in medicine is that knowledge is power, and we have to empower our patients to make the right decisions. There's a lot of information out there, and it's a matter of finding the right information for somebody to make the right decisions for their health. So, and that's at every level we can do that, and it's important.
Excellent. All righty. So Dr. Kaur, tell us about your home visit, please.
It's myself and one of our nurses, and this is actually, she lives in Buxton. Can you guess how old she is?
Well,
100.
By you saying that, I'm sure she's probably over 100.
110.
Well, all right. Yes.
She lives by herself and with some help from family members. And she has a daughter in England who is 88 years old. And she's the only family member in Guyana, as far as I know. But must be something good in the food, or otherwise in her genes, because she's still sharp. Still sharp at 110 years old.
Good genes.
Yes.
Good genes, you better believe it. Wow.
They say it don't crack, right?
That's right.
Beautiful, beautiful, Dr. Court. I mean, I was just so impressed and so amazed when I saw these pictures and heard that you had made home visits. That was so incredible. All righty. And I think I may have a picture. Yeah, these are some, this is in Buxton, and actually this is across the street from the clinic.
Across from the clinic, yes. I think she lives in this house. Olitha knows her very well.
Which
Olitha-
house? This one here, or can you see my pointer?
Yes, I think that's it. Yes.
Right there. Well, you know, the thing also, Dr. Court, this gives me an opportunity. It was so interesting in the country that along the roadside, they had these waterways. And can you do on both sides, can you give us an indication why they do that, or why that's necessary?
I don't know, but it's probably for drainage. I don't know.
Well, keep in mind also, it's a country that's below sea level, right?
Oh,
That's correct.
okay.
Yes.
Yeah.
You know, so just like New Orleans, drainage is very important.
Very important. So it just keeps everything dry, keeps the
Absolutely.
community dry to have these areas
Yeah.
that water can drain. Excellent.
But you know, Omar, I think that you know, you see that a lot of these houses in Buxton are on stilts. And you
That's
usually
right.
see houses on stilts in coastal areas because of
That's right.
flooding. And so
That's
there
right.
must be an enormous amount of flooding that's going on, and that's why people have built their houses sort of
Stilts.
way above ground.
Yep.
Yeah.
And the Dutch built these waterways to help with the drainage. So at low tide, when the ocean is below the seawall, as you may have a picture. There are these there's these devices, these pulleys that come up, and all the water drains out, and then it closes when the tide rises back up, and the seawall protects the coast.
And they're Dutch cokers. Yes.
Yes, Dutch cokers.
Yes.
Yeah.
It also looks very lush, so I would imagine there's massive rainfall.
Oh, we're going to
absolutely.
cover that, Dr. Salam.
Absolutely.
That's coming.
While I have the mic, Omar, back to the case of the 19-year-old woman with the shortness of breath as she walked across the room. Was her mitral valve prolapse advancing into heart failure?
I think that's a possibility. She didn't have crackles in her bases,
Okay.
but it was such a classic murmur for mitral valve that, you know, I can imagine that it was, if she wasn't in heart failure, you know, the symptoms were so significant that she would be there soon, and she needed to be taken care of.
Yeah, you know, and it speaks to the complexity of the team with all the different specialists, because someone like this also, even if her mitral valve prolapse anatomically was not that significant, if she's someone who, and we've seen 19-year-olds in that country with significant anemia secondary to dysfunctional uterine bleeding, whether from conditions like endometriosis or fibroid, that a little bit of anemia in someone like this in a place where, you know, good physical fitness is required in day-to-day life, just to function, you know, to do basic chores that we often take for granted, you know, can make her so symptomatic that she can't function.
Oh yeah, if she was anemic, let me tell you, she would be in the hospital. She would need a hospital, put it that way. Her symptoms, any exertion, you know, she was fine when she was sitting, but if she exerted herself, it was obvious that she was short of breath. Yeah.
Omar, you know, when you talk about mitral valve prolapse, most of the times you think of it as being sort of insignificant, and sometimes you hear it. So the fact that she has the symptoms that she did means that there's probably mitral valve insufficiency, which means that it's probably not functional, which allows for that black that can lead to the shortness of breath. So it's probably not just a mild prolapse. that valve probably isn't working very
Yeah.
well at all.
Well at all for her. Yeah.
Yeah. And and the big picture message here is, where we practice, we have the embarrassment of wealth. We have all kind of technology and all kind of equipment to listen and look. When you're in Guyana, you really have to rely on your clinical prowess, because you have to listen, you have to discriminate between one type of murmur, from the other type of murmur, to actually have a good sense as to the diagnosis. I just remember Kevin and I got called into a case that they thought was an ovarian torsion, and they took her for exploration, and there was no torsion. When we ran the bowel, she has a small bowel obstruction from endometriosis.
Mhm.
You
Yeah.
know,
Yeah.
You-
So
you-
that is
you know-
true.
You know what this speaks to? This is a living example of the social determinants of health. So how where you live, work, and play influences your health and the health care you receive. And that affects mental health as well. So you see it in the States, folks who live in intense urban environments, whether it be a food desert, a lack of safe, open spaces to play, and the impact that could have on health, where you may have a food desert in terms of access to fresh produce, but there's no shortage of fast food restaurants that sell cheap, calorie dense foods that increase high in salt and saturated fats that cause cardiovascular morbidity, metabolic morbidity, and all the health problems that come with that. So this is an example of these factors in action. And I love that phrase Patrick used, the embarrassment of wealth. But everything is about perspective, and we really ought to be thankful for some of the medical advances we have access to. But my fantasy is that this trip was really, really gratifying, that you were able to help people in a ruthlessly efficient way, and folks were just so delighted and relieved to have the team come. I could feel that. It's really screaming at me through the presentation.
Yeah. So
Kareem, I just want to comment about the embarrassment of wealth. And that sometimes is a perception that's not reality.
Right.
When you look at how much money the United States spends on healthcare and the technology that exists, our healthcare outcomes are not very good at all, especially when you compare it to other places. And I dare say that a large number of people, even though a lot of people now have access to healthcare, a lot of times that healthcare is also illusory. That if you have insurance that doesn't pay physicians a lot, you'll see that physicians don't see those patients as often as they may see patients that pay more, and some won't see them at all. And so I think that I talked to Dr. Bay about the trip to Guyana, and was a little bit concerned. I'd never been asked to participate, but anyway.
Well, I'm giving you a formal invitation.
Well,
Right
you
today.
have now, but one of the things that I like to do is I like to look at data and information, and I was although you can tell, and someone mentioned it before, is that the majority of the population lives on the coast, which to a certain extent makes it a little bit easier for people to have access to healthcare. And Guyana, even though it's a small company, they have universal access. So everyone is eligible to get healthcare, and they have divided it up into districts and regionalized it. I'm sure that they don't have some of the technology that exists here, but I think I'd have to say that the government at least has been thoughtful. And one of the things that they're looking to try and do is to increase their collection of data to try and deal with things like cancer and registries and everything else, because a lot of that is problematic. But I think that they must have enlightened government because the number of physicians for the population isn't that bad. It's not bad at all as far as I'm concerned, especially given the way that the that the population is arranged. And I would think that sort of in the future, one of the things that the mission might do is to look at those specialties that are have the least amount of access, that have the greatest amount of problems. You know, you talked about ophthalmology. My guess is there's not a lot of ophthalmologists. And someone mentioned that there were a number of Cuban doctors there.
That's correct.
And Cuba has, as many of you know or don't know, is educated a lot of African Americans from the various countries in the Caribbean and others, and even some from the United States for free to help deal with the healthcare in some of the areas. They have one of the highest number of physicians per population, but I think that Guyana is probably would be receptive to looking at health assistance from especially people that are from the country, either originally or through their parents, that specifically is tailored to the needs that are difficult for them to get. But I congratulate all of you who've been going for years and years and years. And I think that, you know, some people go to Haiti, which has 0.2 doctors per 100,000 folks, and healthcare is abhorrent, and that government is inadequate to address the needs. But I think it's important that Guyana, I think, is looking to do the things that will make a difference going in the future. And I think this medical mission might work with them to try and coordinate in the future additional needs that they might have.
You know, Dr. Sprott, that's such a good way to summarize the whole experience. For years, I've been saying one of the reasons it's pleasurable for me to go to Guyana is they have a good infrastructure. The other point I make to the folks that we take along with us is that we're not heroes going to save anyone or anything. We're going to complement and supplement what's there. Because one of the things that fascinates me is how these young doctors, one, educate and gain their own experience. Oftentimes, you know, with little tertiary level supervision. I mean, we have the ability and the fortune of getting out of medical school and going into residencies. And going into residencies where you get graduated responsibility as you grow and gain experience, and also your status in the medical community and in the medical societies increases. And there's a hierarchy that, you know, there's always opportunities to climb that ladder. You know, coming out of medical school, you know, these guys come out of school and then they're in the emergency rooms, you know, then they're on the floors, and, you know, they build from their colleagues who are ahead of them if they can build those relationships. And if you can't, you're stuck. And I can tell you, you know, I was hoping we'd get to the lap colis, right? Some of these these two young surgeons who in that area where we went, when they started lap coli with some of the equipment, you know, first and second generation equipment that we donated, you know, even the medium to afford them good visibility, you know, they didn't have medical grade CO2 to use, but they found an alternative, right? So Guyana, I think, has a very good infrastructure. And I think, you know, and my experience is they try to touch on all specialties. In Guyana, mental health is a big issue, right? And you know, we've often seen other groups from other countries at various times when we're there coming in and try to employ various techniques to help with the mental health issue. You know, the issues of suicide, you know, with kids getting admitted for drinking things like antifreeze.
So I would disagree with you guys that even though there's universal healthcare, there's a problem, and then we see the same problem in other third world countries. All the years I've been going there, the influx of Cuban doctors, yes, they are helpful and they help train, but the success of a healthcare system or a training system, you see that when you no longer are relying on external physicians to supply factors in the healthcare. The fact that the anesthesiologists are all from Cuba, for the last 6-7 years is problematic. So, right, there are good things, but you can see that there are certain, there's definite problems within that infrastructure because one, you have a training program, but you have not filled key positions with locals. And to me, that's always a sign of a critical issue within the healthcare system. It happens in a lot of other countries too. There are lots of guys.
Kevin, I always like to take exception when you disagree with anything I might say, but I didn't say, I didn't say that things were perfect, but let me just say this. The life expectancy in Guyana is increasing,
Right.
whereas the life expectancy in the United States is decreasing. So, the gap between life expectancy in Guyana, which is 70.1 going up, for men in this country is 73. And if they're going up while we're going down, they may catch us. There are 19 other countries that have better healthcare outcomes than the United States. So my point was not that they're perfect, but I'm saying that they have a plan that appears to be working. The vaccination rates are very good. So, I'm not saying that they have the best access to care, because if you wouldn't have the numbers of people that are coming to the clinics to see you. And I'm sure that there are healthcare specialties that are clearly lacking. But I think that it seems to me, again, I'm just overestimating that the government is interested in planning and certainly welcoming you and setting things up so that things can go clearly. I mean, some of the medical missions in some of the other countries, it doesn't go like that in Haiti.
Yeah,
I think Dr. Sprott.
And Patrick,
Wait,
I'd love to continue.
Shouldn't Kevin be allowed to finish?
Hold on.
I don't think Kevin
I'd love to
finished.
continue this because
It's a little bit
we
beyond the
take
scope,
this,
and actually we can.
take this, but we're going to keep going on this mission of the mission.
Can I say
at the
one thing,
moment.
though?
But hold
Can I-
that thought, because
Omar.
I think all that you're saying is valid.
Omar, I have to.
Mhm.
Just from my example with my girls, I think what we need in Guyana, they need a postgraduate training. You can't have kids coming from Cuba or wherever, and the next day they arrive in Guyana, put them to work in the interior. My girls have come quite a ways. And now, like I said, during our presentation earlier, they're competent now. And I think if anyone can do it.
And I think if I can add on what Dr. Court just said, listen, no system is perfect, okay? I think Guyana has made tremendous progress in terms of trying to fill family practitioners to kind of screen and do the basic medical care there. And from a surgical perspective, they were hoping to do a similar thing whereby they can have these community surgeons to take care of basic needs. That was the whole point. But from an advanced training program, and I don't think we can compare it to the United States, from an advanced training program in terms of that postgraduate training program, we don't have it. And that's the big difference.
Yes,
but
it
I
is.
think it's a work in progress. And with time, they'll fill that gap.
But I mean, correct me if I'm wrong. I mean, for the years I've been going, I mean, I've seen, at least at the University Hospital, now they have postgraduate training program in women's health, in surgery. And I think over time, we shouldn't get into, make good the enemy of perfect. But can you hear me? I think I got disconnected.
Yeah, no, you're good.
Now we can hear you.
You're good.
Yeah, but we see these postgraduate training program, and one of the young ladies we were working with this year is actually a resident who was rotating from the university hospital out to that area. So so it indicates that there is progress with respect to utilizing and working within that infrastructure to educate the young people when they come back from medical school.
That's true, Pat, but keep in mind, and I know this is really not part of the mission project here, but keep in mind that the influx of those students who are coming back, we don't have enough room to accommodate them for them to do what their desires are. So that is a major, major issue. So you have a lot of folks who are sitting on the sideline and not quite sure what to do with their lives. So that's one of the downfalls. But I think with time, the Guyanese government will get that together. It's a work in progress, and I strongly feel they will. And also going back to that program that you're referring to, it's really a short program. It's a 2 or 3 year program, and you really need a good 5 years in general surgery really to go out and feel competent in most things. So they're really training them to do some basic things. That's what the program is, basic community things.
Excellent, excellent. All righty. So again, these are some, and I just touched on some of the other clinics that we service because the program would have been too long if I touched on all of them. So I'm just going to go quickly. As you note, see here, Dr. Ali and Dr. Mangra joined the mission, and they were at this particular clinic. And this is the last clinic of the day. Sophia was the one that I was in team 1, and then there was the other clinic. And it was just, you know, a joy to, you know, be a part of this mission. I'm really serious about that. Just a joy to meet the people, to see how they live, to see the culture. It was so good. Now we're going to go into surgery. I know that our time is almost coming to an end. I'll let it extend a little bit because I want to really get through this. This is orthopedics. Kevin, can you give us some understanding of what I'm going to tell you about this patient, because this patient initially came, this was one of the first days that we were there. This patient initially came to one of our clinics, and actually I saw this x-ray and I was like, we have to get this person to the hospital, because it was a person that had bone fractures, and they had the rods placed in, and it was a non-healing fractures for months and months and months and months. And Dr. Goings, go ahead, Patrick or Kevin, and you can tell you know, just give us some indication of what you think that Dr. Goings did for this patient.
So, not knowing all the details, what I can tell you, it's a very bad fracture. I don't know if you can see, but it's a multi-segmental fracture. I don't think it was an open fracture initially, but it was rotted at the initial operation. I think this patient, actually, the reason why it didn't heal is because it was infected. And the fact that it's infected, it wasn't managed, at least from what Chris had mentioned initially. It has to be treated aggressively. What's gonna happen now, what he did there with that procedure, he took the rod out and just put external fixators on, which is what you do when you have an infection, especially within the bone. And then later on, you may go in and try to put the rod back in. But this person, from what he was saying, is at serious risk of limb loss. And I think when you're in third world countries, there are things that you know that if addressed appropriately, the outcome is, you expect the outcome to be good. I'm not saying that this is something simple, but the risk of limb loss with a fracture like this is relatively low when you have all the resources available to you. But in this case, it's a real risk potentially of this person losing their limb.
Yeah, Kevin, if I might come, what I remember of this case is a young woman who a lot of the people in the hospital actually knew her as a child growing up, and were a little bit distraught as to, you know, the outcome here. But what fascinates me about orthopedics, at least where we were, is the passion with which these guys approach, you know, every situation they face. bear in mind, these guys, they go into the operating room without even their, at least the X-ray equipment that we are used to, the C-arm, where they can do analysis of their work in real time. And these guys are so used to taking static X-rays in multiple planes and making treatment decisions with these static X-rays, with most of the time with good outcome. But like, as you mentioned, the issue with this young person was there was infection in the bone, and the initial repair had to be dismantled so the infection could be adequately treated while supporting the bone using an alternate means in the meantime.
Yeah, and talking with Dr. Goins, he felt that this was going to be an excellent outcome. Believe it or yeah, excellent outcome. He felt the patient was going to do well. All righty. This is just him doing another procedure and making sure that the leg is stabilized and a successful surgery. So just to let you know that many types of surgery was being done, and he was very encouraged that these people would have successful outcomes. All righty. Now, Dr. Alves, this is you're up. We have the lap chole here, and we have the thyroid.
And we can spend a little time on the lap chole. That was a question that was raised earlier.
Yes.
And it's removal of the gallbladder. It's removal of the gallbladder using minimal invasive approach. And generally, what we do, we make either 3 or 4 small incisions, and using the laparoscope, we were able to remove the gallbladder with the gallstones. And as Dr. Ali mentioned earlier, gallstones can be a reflection of diet, and most times they are. And it has to do with the amount of cholesterol that's within the system, the amount of cholesterol in combination with bile salts. And generally, if the amount of cholesterol exceeds the bile salts, then the cholesterol falls out as little as cholesterol stones within the gallbladder. So oftentimes these patients who are symptomatic will present with a stone that's blocking the neck of the gallbladder, whereby now you have a hollow viscus that's unable to empty. And that will give you excruciating pain in the upper aspect of the abdomen, primarily in the right upper quadrant, and that radiates towards the back and sometimes around the right scapula. So there are numerous tests that we can do to determine as to whether or not we're dealing with a gallbladder issue. But once that decision is made, and oftentimes it's made before we get there, so that patient gets on the list. And the ideal way of doing it is to do it laparoscopically, because doing it laparoscopically, we're not cutting across what's called the six-pack muscle or the rectus muscle. I have done many of them open in the past, and I tell you, out of most laparoscopic procedure or minimally invasive procedure, at least from a general surgery perspective, this is one of the few that truly, truly makes a big difference.
All righty. Yeah, it's a great procedure and quicker recovery time. Yeah, great procedure.
Oh,
Yeah.
you do it open, and oftentimes, as I said, I've seen patients come back 6 months later and say, "Gee, Dr. Alves, I have a heaviness on the right side of my abdominal wall, and it's a persistent pain that they go through for a fairly long period of time." So the data clearly show that one of the few procedures that truly makes the difference is the lap chole. And the lady off to the left is a large goiter for which she underwent a thyroidectomy.
And again, I want to emphasize the folks in the picture with Dr. Alves, those are the local residents. So
Absolutely.
this is the session where, again,
Absolutely.
helping to teach the local staff.
Yes, and as I want to piggyback on that a little bit also. As I said earlier, the objective is not just to go there and operate, but to help and to enrich them from a surgical experience. That is the local guys. And case in point, I have had two relatives over the last year that I have actually sent to New Amsterdam Hospital to Dr. Al Gu, both of whom he actually operated upon. And I was very pleased with outcome.
Excellent.
So this is the kind of infrastructure we have, and this is the kind of connections we're making. And I tell you, you feel good when you know that the person you're referring family members to is someone that you have worked with and you were involved in their training program, because when Patrick and I started, Algu was in training.
Yeah. And bear in mind, one of the things I echo is, all the equipment that Dr. Alves is using, right? Some of which he brought, but these guys, they modify some of these equipment to make it work with the infrastructure that they work within day in, day out. These guys, Algu, Prasad, what's his name? Ram Prasad.
Yeah.
These guys, they in a different place, these guys would be upper echelon type. They would be competing with Kevin for his spot. I mean, some of the stories, some of the stories that they tell, some of which are just too open to having this discuss in this forum, is just mind blowing.
Just an observation, Omar.
I have a question.
Hurry up, Kareem. I just wanted to make an observation. One is that I've been impressed with the ORs, how they look clean and equipment looks new and sort of up to date. And the other aspect is when Dr. Court talked about the young ladies. And one of the things that we've been sort of trying to do is encourage Black men to go into medicine, but the women are going into medicine at 8 times the rate of men, and they're sort of the future. So we're not discouraging that at all. But I noticed that a large number of the healthcare staff, the physicians and nurse practitioners are women and appear to be doing great work.
Great work. Great work. Yes.
So my question about the lap chole, the stones, are they confirmed, the presence of stones, are they confirmed by imaging before
Absolutely.
you go in?
Yes. Yes, they do get ultrasound prior to us getting there. Yes. So before they get on the schedule, they're worked up with at least an ultrasound. So we're not just doing things willy-nilly. Yeah.
All right.
Yeah, but also bear in mind that we're always open to adjusting our thought process once we get into the abdomen and realize what's going on, because again, an ultrasound for certain condition may be okay, but sometimes an ultrasound is all you have to make a presumptive diagnosis, right? As opposed to if you had an MRI or a CAT scan, which may not be available. So the ultrasound with your clinical acumen, steer you in one direction. And if you get in and that's not it, that's what's fascinating about these guys. They make the adjustment right away and do what's appropriate.
Excellent. Now, the next slide, I must apologize for the graphic. The Dr. Clark
is that my fault
on this slide? So we shall move forward, and he's going to describe exactly what's going on.
I think this is your case, Pat. This is the one with the big ovarian mass.
Right. Yeah. So chronic pelvic pain, large abdominal pelvic mass, a complex mass between an ovary and uterine fibroids with endometriosis. So this is actually, a hysterectomy with removal of that large mass.
Excellent. And a team approach. I mean, with the gynae surgeons and OR staff, as well as you guys, you were doing an amazing job. All right. So that's our slides as far as that's concerned. But let's talk about unexpected occurrences, and we're going to end up with and move through as quickly as possible. I know we're going a little over time, but I think it's important that we continue. And number one, we were talking about the side roads and the waterways. Well, understand the first day that we got there, as soon as the clinic was over, it started raining. And as you can see, the raindrops look like hail. That's how hard it was raining. So, Dr. Salam, I'm sure those waterways along the road and the houses being on stilts is the reason for that, because it rains so hard. I mean, goodness, I mean, the beautiful when the sun is out, but when it rains, it really rains. Okay. The next thing I was interesting is that as we drive down the street, it seemed as though the animals knew what time to go home, how to get home, and if it was crossing the street or walking, you see the horse there, he's walking down the middle center lane, the grass in the center lane between cars. And it wasn't just one horse, it was many horses going down the street. Nobody guiding them. They're just walking. It's so interesting to me that the animals really know when to go home and how to get home. And crossing the street is no problem. Excellent. And this is, Patrick, can you tell us about what happened?
Oh, I think we were trying to make it back for our final event there, the last day. And, you know, we're moving along, you know, the ride got a little bumpy. You know, you hear the typical sound that suggests that there was a problem with the tire. And, you know, we hopped out, changed our tire and kept going.
That looks like more than a problem.
Hey, Patrick, could they fix that tire?
Well, you know, I knew how to change the tire. The driver and I, you know, I think 20 minutes in the rain and we were done.
Oh,
That
I'll
tire
tell you,
is hopeless.
Jack of all trades, Patrick. I don't mean that as a pun, like Jack in the man.
Wow.
But you did a yeoman's job. Doctors change the tires. I like that. I like that. All righty. So, you know, after days like that, we need to have a little, just a little fun time. And the staff definitely is just so great. There was another thing that in Georgetown, there's a place called, and where we stayed, right down the street, there's a place called White Castle. The first time I went, they said that we were going down to get some fish at White Castle. Well, guess what? The first thing I thought of was White Castle, the type of White Castle we have here in New Jersey. There's no way I wanted a fish sandwich from White Castle, but it convinced me that it's not the same White Castle, and I'm so glad they did. The food is excellent. And that is just some of our team there in front of the sign, letting you know that we're down there at nighttime getting dinner, and it was a wonderful time. The food is excellent at White Castle and Georgetown. Well, the final thank you party. And Dr. Court, you know, this is something that I think everyone, you know, just had a great time and appreciated. And, you know, it's just a wonderful, wonderful mission that you and Audrey and the others that are able to put this together. It's just a wonderful, wonderful thing. I'm going to go through these pictures. If you can kind of take over, Dr. Court, and kind of describe what's happening. I know that these are general pictures of some of the you know, staff and people that were at the mission and just having a great time at the final party that Friday night. This is Dr. Nurse. She's the first in line getting some great food, Chinese food, as Dr. Ali said. And you know, the ophthalmologist here, yeah. It's just a wonderful night in the event. Dr. Court, I'm going to let you take it over.
I'll let the pictures speak for themselves. Come on, hit it.
Yeah. Well, yeah. This I just want to make thank you for that it was a mission was accomplished. Dr. Griffin, this was the Minister of Health. This is the female in the middle. That's Dr. Griffin, Ministry of Health. And then Dr. James Melville, we haven't mentioned him before. I mean, excuse me, Mr. James Melville, we haven't mentioned him before, but Dr. Court, I have to say something about him.
He is the best. He is why the mission occurred. This is the man that goes to Pennsylvania, drives 4 hours to get our stuff from the place that we get our equipment and medications from. And there is nothing that you can ask James to do that he wouldn't do. This time he brought along his sidekick, Andrew, and they were wonderful. Without them, this couldn't happen. Of course, he
Well,
works together with our queen.
I was gonna say, Dr. Court, case in point, I approached you about a ligature for New Amsterdam,
Yes. Hmm.
and I reach out to James. And within 24 hours, he had an answer for me. And the answer was, I have one, and you will have it. So that's the kind of individual he is.
And he doesn't
He-
like to be recognized.
You know, he spends a lot of his personal time making sure that things come together in the appropriate way. And it's all for the people of Guyana.
That's correct.
Yeah.
That's correct.
All righty, excellent. Dr. Alves, you're giving an award to, I think it's one of the residents, right?
Yes.
Yes, that's Patrick.
So every year, we try
Chief
to
resident.
bring a surgery resident or a resident in GYN. This year we brought a recent grad, someone who graduated like a month ago, and a current chief resident. Just so they can experience what it's like to, practice in an unfamiliar environment. And these young ladies were, they work well with the nurse practitioner. They work well with the general health officers. One of the things they've done over the years is they create this network where they share their information to some of like our ACOG committee recommendations, how to manage certain things. So for these guys, it was a really good experience. They make rounds on the ward with the in-house team, and add their experience to what they're doing. And for them, it was a really, really, really good experience.
Excellent.
Patrick, if I can just add one other thing, I'm gonna go back to the late Dr. Suresh.
Oh,
We generally get up at about 6 o'clock in the morning, and then we'll take a 30-minute walk. And every time we did that with the late Dr. Tani and the residents, he always had a good story, a story of wisdom, be it of life, be it saving money, be it practice. He always had something very good that they can hold on to. What a great guy that we lost.
Yeah.
Too soon, definitely.
Yes, too soon.
May I mention the gentleman to the right? He is part of our affiliate. He belongs to our sister group in California, Guyana Medical Relief. They have
Excellent.
always helped us in many, many ways. And we just had to recognize him. As a matter of fact, with him was Dr. Scott and Dr. Goring. They belong to the same group.
Oh, excellent,
Yeah.
excellent.
And those are our 3 drill sergeants.
There they are.
Without them, no mission.
Yep.
They would organize those places in a couple of minutes, man, and we could start working. Yes.
Yeah. So when we came in, they would go into wherever it was, the clinic or the hall, and set up. Doctor's going to be here, the pharmacist here, the eyeglasses here, the triage here. Let's go. And in about 15 minutes, we're seeing patients.
Right.
They are excellent. All righty. And, the end of a fantastic week. This is a photo. Yeah. I'm sorry that I had to leave early and I wasn't part of this photo, but I'm sure that you guys had a great time. And talking about having a great time, there's no way to end a party a great mission like a party.
Where are the men?
Dr. Court, I don't see you on the floor.
My stomach.
That's spicy food, huh?
Yeah,
That's
man.
spicy food. Well, I know one thing, Dr. Ali is there.
Mm.
there she is, Queen Audrey.
Yes, he is. Yeah, Patrick, I was wondering, and Dr. Clark, come on, man. Why, you got to hold up for the brother.
I don't know what happened. I think we were doing it, but we were doing it in the dark. We didn't want anyone to
I
see
see
it.
everybody's at the bar.
All righty, excellent. Well, all I can say is, Dr. Court, I just got to give you and Miss Audrey Fredericks Edwards all praise and what you do for the Guyanese people and setting this mission up and how well it's run. It's amazing. And I know that there are so many people behind, all of the glamour that's doing the hard work. And I would just like to say to each and every one of them, we appreciate you. Keep doing it. It's for the greatest cause that you could ever imagine. Health is everything. And if we can help people, then we should do that. I remember my dad used to say, there are three things in life that he loved to say. And this is one of them. He said that, excuse me, my phone just went off. He stated that we all are born with gifts, be it whatever it is. You can run fast, you can read fast, you can memorize, whatever your gift is. He's like, the fact that you're born with a gift is great. He's like, but what do you do with it? Do you mature? Do you allow that gift to mature? Do you develop that gift that God gave you? And that's a question. And many of us, do develop our gifts as far as, and so the first thing is that you are born with a gift. The second thing that you must develop your gift. But the third thing is that you must share your gift. And I think that each and every one of you are sharing your gift that God's given you. And it's such a great thing. So Dr. Court, as well as Audrey, thank you very much. And all of those who work hard to make this a successful mission. Thank you very much. Is there any other things to say? I mean, Patrick, you were there, Kevin, you were there, Dr. Ali, you were there. Tell us what you feel, please.
So, my gratification doing this trip is, one, we don't have a whole lot of time to do a lot of things, and we did a lot in a short period of time, right? So, that speaks to the organization. It speaks to, the welcoming of the Guyanese government, the Ministry of Health, and the people who come to us to give us the opportunity to serve. The other thing that I just thoroughly enjoy is to be able to spend time with my colleague in doing the work we do, but in a not so pressured environment. And for me, the colleagueship, the ability to share reverence with local Guyanese people, appreciate what other government planners can do to influence life for people who are not so fortunate. For me, that's just gratifying.
All righty. Any final words, Dr. Ali?
I agree, and I was very honored to be a part of this. As a physician, we have a lot of constraints in our schedule and demands of life, and really why we choose to go into a path of medicine is to help others. And really, sometimes we get sidetracked in our day-to-days and where we live and what we're doing, and working with difficult cases, working with this administrative side of medicine. But this was a great thing for the professional soul, for me, what it did was it helped me just kind of rejuvenate myself in why I do what I do and why we take care of the people that we do and why we chose this path of life. It's not just a job, it's a life that we choose and an oath that we take. So it just helped me to reaffirm why I do what I do, and I love that I did. And I thank everybody, all my brothers and sisters here that made this mission an incredible experience for me, and I look forward to doing it again.
All right, Kevin, do you have any parting words?
I mean, I think Dr. Ali and Pat pretty much said it. I think it's an honor to be able to participate. I think giving back is important. It actually, you actually get to some degree a lot more out of it than you would think. Even though you're going there performing a service that they may not have, or they may have but don't have enough resources. I think what, having done this for probably about 8, 9 years now, one of the things is I want to be able to, it's sad that we have to do medical missions. And when you think about it, it's a situation where it shouldn't be where we have to do this. And that kind of, when you reflect and look at it, it's kind of sad.
All right, but we're going to make it better.
Yes, yes.
Yes, sir. Dr. Lennox Alves, please say something to us.
Well, I echo the things that were said before. I want to make 2 points. One is, Dr. Salam, you talk about the way medicine or the way surgery is practiced in Guyana. I just want to emphasize that the patients that underwent major procedures, such as hysterectomies or maybe gallbladder surgeries or exploratory laparotomies or hernia repairs, you would be shocked to see them out of bed the next day with the equivalent of Motrin.
Mhm.
Motrin, the equivalent of Motrin. Not morphine, not Dilaudid, not Percocet. If I did that here, I think they would report me to the board. I would be reported to the board. But I think it's a good point to note. Going back to this year, I felt it was a special year in the sense that we missed 2 years due to the pandemic. I think the camaraderie that we had this year was special. For me personally, it felt like a close-knit family. So I truly enjoy this year. Not that I didn't enjoy the previous years, but there was something special about this year. I truly enjoy being with you guys.
And Dr. Alves, I must tap into that. I think that the people there, because of their lifestyle and what it takes for them to be normal every day. And post-surgery, getting up and only needing a Motrin to get out of bed and walk is no big deal. It's just
That's right.
a different environment. It's a different
Different
thought of life.
expectations too.
Yeah.
Different expectations.
So that's just the way life is for them.
Yes,
And
yes.
it's so gratifying to see. And
Yes.
it's just, to be a part of that is just so great.
Yes,
Yeah.
absolutely.
So Dr. Cord, I want to leave the last parting words to you, because before we sign off, what do you have to say?
Thank you. Thank you all for giving up your time and money. Come and help or supplement or complement Guyana. My only regret was that my brother, Dr. Saunders, didn't live to see how far we have come from when we started. As a team of 2, he's gone forever. And I'm sure he's looking down on us and said, hey, keep on going, boy, keep on going. Thank you so much.
Excellent, excellent. So in closing, I'd like to thank OBHealthy for allowing us to bring this webinar to you. Understand you can go and download their app for their health information and weight loss and all of the good videos that they have for health education that's geared to people of African descent. It's so important. Understand this webinar is every second Saturday of each month at 1 o'clock. And please tell others about it. It takes a village for us to do things like this and to educate our people. If you've missed any of the past webinars, you can go to OBHealthy and click on the YouTube sign and you can visualize any of them, and it's worth going back and taking a peek. I'd like to say what I always say is please do not change any aspect of your medical care until you talk to your physician, because only your physician can truly take care of you from a medical standpoint. All righty, and I think that's it for this month. I look forward to seeing each and every one of you next month. And until then, I'm going to say peace and take care of yourself. Okay. Bye-bye, everyone.
Bye-bye.
Bye-bye.
All righty.